Our next discussant will be Brandy Biderman. She is a practicing nurse practitioner. Been in Chattanooga for many years, and she is specializing in diabetes and thyroid disease. She is a proclaimed type 1 diabetic, and she's since age 12, and she brings that personal touch to the care of her patients. She's actively involved in the JDRF, the Juvenile Diabetes Research Foundation board at board level, and is actively involved in researching the efforts to find a cure for type 1 diabetes. So if I have Brandy up.
I will not delay us, I promise. I will stay on time. It might. So when Chris asked me to do this presentation, I was surprised. I thought, I've been treating diabetes so long, my main goal is to not ever have to refer to vascular. So I was pleased to come and present today. Some objectives for us will be the clinical presentation and identification of the pre-diabetes patient, early initiation of treatment, utilization of GLP-1, and of course SGLT2 inhibitors. So when this patient comes in, you need to know what you're looking for, because they don't know what they're coming in for. They're going to come in and say, you know, I've gained so much weight, nothing is helping, this is just getting worse and worse, I'm working out, I'm meeting with a trainer, I'm eating when I'm supposed to eat, I'm eating clean, that's my favorite comment. They're like, I'm just continuing to gain weight. They're tired because when they're eating these things, if they're eating something carbohydrate loaded, they're gonna need a nap immediately afterwards. They're gonna be fatigued. They're gonna be probably urinating more than most others due to the high glucose levels. Some of them come in and they say, you know, I'm having hot flashes after they eat something carb loaded, something they know they shouldn't. They're like, I'm hot. I can't deal with this feeling. The other ones are going to be uncontrollable cravings. These people will tell you they're eating things that they've never craved before. They are looking for sweets, and they're looking for fries, and they're looking for things that are not on a typical palate, because once the body has an elevated insulin level, then those cravings come very natural to us. So I guess the first thing you need to worry about is differentiating, are they pre-diabetes or are they indeed a type 2? So there's testing that we do when they come in, and that's with your initial assessment. Blood-wise, you're looking for an insulin level, a C-peptide, an A1C, and you can see when you diagnose somebody as type 2, you've got the ACE guidelines. It's out there. It's laid out. It's saying metformin is your gold standard. It's asking for GLP-1. It's asking for SGLT2. And those guidelines are very specific, and they're laid out, and there's no question. There's not a guideline specifically for pre-diabetes that you can just go, this is what we need to do. You sort of have to glean that in your own practice and make that work for you. When I typically diagnose pre-diabetes, they're going to have an A1C 5.7 to 6.4. They're going to have a fasting insulin greater than 20 and a C-peptide greater than 4. Now, these numbers aren't set in stone like some of the others from the ACE. You can have a completely normal A1C, and you're going to have an overstimulated insulin level as well as a highly elevated C-peptide. In fact, it's pretty common to have a normal A1C with somebody who's insulin resistant. Again, these are just some points that you can pay attention to. But if they're over 6.5 on an A1C, or you have a random greater than 200, you can go ahead and bust right over to ACE guidelines. There's no reason to not. But in the kind of gray area of pre-diabetes, insulin resistance, whatever you choose to call it, those are your guidelines to go by. Again, the 5.7 to 6.4, greater than 20, and greater than 4. Some people don't draw a C-peptide. They'd rather do a glucose tolerance test. I'll be straight with you. Patients don't enjoy glucose tolerance tests. They're long, they're messy, they take a lot of time. You're going to get the information you need from these tests. My practice doesn't use oral glucose challenges anymore. So, like with every vascular issue, prediabetes is not different. The key is early initiation of treatment. Everybody that comes in is going to say, well, I'm following this diet. I've tried low carb. I've tried keto. I've tried Whole30. I've tried Atkins. It works for a minute, and then it stops working. I think the reason they understand that is because it does work for a minute. They're motivated, everything's going great, they're working out, they're following it, and then they still have that hormone deficiency that we'll talk about in just a second. So without replacing that hormone, they do get frustrated. They lose the weight, it comes back. They lose the weight, it comes back. And then when they come in, that's that frustration piece that you're gonna pick up on, and that's where you have to intervene again. I think we've covered the C-peptide, insulin level. You guys are good there. Time analytics, when you consider an A1C is not as definitive as we used to think it was. If you've got a patient hovering in the 200s and then the pancreas is overproducing and then they're crashing into the 40s, you're not going to get a true representation with that A1C. You're going to get what I call a false A1C. You can also get it if they're anemic. So I like to use time analytics-based software with a Libre 2 or a Dexcom G6. These are available as samples, or the companies have programs where they can get one for free. If they have private-based insurance, it's generally not that difficult to attain one. The software goes on any phone, any handheld smartphone, and it's not expensive, it's free. So it's an easy tool for us to utilize. Time and range, if you explain a patient time and range, and I'm generally looking for 70 to 140, and the 140 is only for what they're using after meals to make sure that they're coming down. But if you can explain time and range to a patient and they watch it every day and they're looking at what they're eating and they're looking at their breakfast and then they're looking at their phone and they're saying, this smoothie that I made with like 2 bananas in it and this yogurt spiked me to 220. I did not feel good this morning. But then the next morning you're like, look, try a low-carb breakfast. Try something that's not going to hit you super carby, not going to overwhelm your system. And then they realize that if they did one of the low-carb preparations or a protein shake or something of that nature that truly was low-carb, they're not going to spike. They're going to have better energy that morning. They're not going to be fatigued. They're going to be killing it at work, wherever they are. They're going to be on point, and they like that. They like that feeling. They like having that back. So time and range is current, it's dependable, and it's easily accessed, and patients do really well on it. So not that we're getting away from A1C, this is just more dependable in my opinion. You can use whatever you feel comfortable with. These are just what works in Hickson, Tennessee, over in my house. So medications most frequently utilized for prediabetes, I think you can't discount metformin. You have to use metformin. It's a gold standard. And insurance is going to want you to start with an extended release. I don't use the immediate release because of the GI effects. When people come in, they're like, don't you say metformin to me. They've had it. They know what it is. They've had immediate release, and they're not going back. I don't blame them. XR still has some GI side effects, and patients will try it. I generally ask them to initiate it at bedtime, so hopefully they will sleep through any GI effects. But if I have my choice, I go with one of the combination drugs that's currently available. It's extended release metformin combined with an SGLT2 inhibitor. There are currently 2 SGLT2, and well, there's currently 4. 2 that are most heavily used, specifically in my practice. I didn't list all 4 because I have better coverage with the ones that I listed and easier access for patients. So it's IMPA and DAPA in my world. And you get the insulin sensitizing portion from the metformin. So patients are utilizing their own insulin much more effectively, and they're not having to make as much. So that instantly gives you weight loss, which is what they're all looking for. The SGLT2 portion is going to prevent the reabsorption of glucose back into the system, and then you just secrete it out of the kidneys through the urine. So you get better glucose numbers instantly. Specifically more about SGLT2 inhibitors. IMPA, empagliflozin, if you'll go there, most of us just call it IMPA. I won't use the brand name. It's oral, it's daily. There's a plain form, and then there's the combo form that we were talking about. If you do the plain form, you will use it with metformin XR that you get at the pharmacy. They'll need to do probably 1 to 2 pills in the morning and 1 to 2 pills in the evening, and then they'll use the SGLT2 in the morning. The problem is it gets a little clunky. If I can get a patient 1 pill and it's got the metformin in it and it's got the SGLT2, I'm instantly getting better compliance and I'm getting what I'm looking for. So my numbers look better, the patients are happier. There's some barriers. Any payer is going to tell you they want you to fail metformin first before you can move on to one of the combo drugs. But there are also some very good deals for patients through coupons and through other resources. Expectations of this is improved glucose levels, weight loss, decreased fluid retention, and increased satiety. So it's not without side effects, though. Probably 20% of people, whether they're female or an uncircumcised male, are going to develop yeast issues. It's not any reason to stop therapy. You treat it and you move on, and they most likely do not recur. But if you have chronic yeast or chronic UTIs, things like that, that's definitely a reason to discuss with the patient in a different therapy. The next portion of the prediabetes workup and the prediabetes treatment is going to be GLP-1. I really feel like GLP-1 is the cornerstone not only of diabetes but prediabetes. And it's that gut hormone that we're looking for. It's the one that when you don't have it, you don't have a hunger. I mean, you don't have control of your hunger. You're always hungry like a newborn. You're one to eat and eat and eat and eat, and there's no switch to turn it off. When you have GLP-1 on board, you can control those cravings. You can see your favorite food, and you're like, I'm okay. I can go without it today. When the GLP-1's working effectively, people make better choices. They're not going to grab the first thing they see. They're not going to come home from work ravenous and open the cabinet and go for just simple processed carbohydrates. They're able to take their time. They're able to pace themselves. It does cause like an immediate satiety with the injection, almost a fullness. When you're eating, you'll feel it, and you'll feel the need to stop eating. Some people are able to do that and push their plate away and walk. Some people are not. So when they get that feeling, if they overeat, that's when you get the people complaining of nausea, vomiting, other GI effects. But generally, if you educate those patients on the front, they're okay. You say, start with half of what you typically eat. Start with your protein. Don't eat your carbohydrates first. Take your time. And then they're like, wow, I'm not hungry at all. I can exist on a protein shake all day and have great energy and not be hungry through lunch. These patients don't want to eat necessarily. It's either by habit or without the GLP-1, they simply don't have that control. It's the same with bariatric patients after their procedure. Some of them do amazing. Some of them don't. GLP-1 seems to aid those patients well because they have more control. And in the end, I think that's what we're looking for in this class. So there's several in class, but there's two that I depend on in my practice. One is dulaglutide. It's injectable. It's weekly, and it's a one-and-done pen. And by one and done, I mean you pop the end off, you dial it to unlock, you pop the shot, and you throw it away. That helps me, again, with patient compliance. They're not having to keep up with the pen. They travel, they throw it in their carry-on, they pop it whenever they're on their trip, and they're done. So that works for a large majority of my patients, and it's available in like a 0.75, 1.5, 3, and 4.5 milligram strengths, so you can titrate accordingly. Most people respond immediately to 0.75. Some need a bump to 1.5 about 4 weeks in. The other option that I utilize a lot is semaglutide. It's injectable, it's weekly, it's a multi-dose pen. For those of you familiar, it's more like an insulin pen. You attach your needle to the end, you've got dosages from 0.25 to 0.5, and then the next pen is going to be a 1 milligram that you dial in. That pen comes in handy when you have an older person who's presenting with prediabetes, or you're dealing with a person who we know has a known GI sensitivity and you need the ability to titrate that. If you want to go from a 0.25 to a 0.5, but you need the ability to come back down to protect that patient, this is a great option without having to write another prescription or have the patient have to come back in. Semaglutide also has an oral form. It's been out for a year or two. Data is very similar. It is daily, so that patients frown on that a little bit because they want to just do things as little as possible. So when they take one in the mornings, you have to give it roughly an hour. Some people do much longer, but you need at least an hour for it to absorb. And it's going to give you similar results to the injectable, but some people aren't willing to give it that time in the morning. Some people want to wake up and go immediately to their Diet Coke or their coffee or their breakfast. So that's where I get most pushback on this. There is similar GI side effects, and patients start with a 3 milligram and they can titrate on up the line. Just depends on what's most effective for them. Expectations of these medications is going to be weight loss, decreased appetite, decreased cravings, lower glucose levels. The efficiency of your own insulin increases. You're going to have decreased hepatic glucose, less fatigue, and increased energy levels. In conclusion, it's not a lot different than the high cholesterol we've talked about or anything else. The earlier you get on board with these patients, the sooner you identify these patients, the less side effects we're dealing with. We're not dealing with the vascular complications. We're not dealing with the heart attacks. We're not dealing with the bad parts of diabetes, the things you hear people complain about their grandfather losing their leg. If you can get on the front side of it, you can completely reverse insulin resistance. It doesn't have to progress. But we see people waiting. We see people waiting until the patients have an A1C of 8, an A1C of 9, and they're like, oh, we got diabetes. Let's start working on it. I don't know why. That's not how it works in my practice. The minute we can identify it, we get on board, and we utilize the tools we have with GLP-1 and SGLT2s, and we're making a difference, and we're not seeing the progression that we saw previously. Thanks a lot.
So we've had a great afternoon talking about some of the major risk factors, smoking, and cholesterol, and diabetes, and we have to round this off now with hypertension. And so I'd like to introduce Dr. Anthony Avatable. Many of you know him. He's a physician that opened the River City Family Medicine group, and he heralds from California. I think he did his Bachelor of Science at Cal State at Polytech and did his Master's of Science in Microbiology. He had earned his medical degree from the College of Osteopathic Medicine in the Pacific at Panama, and then transitioned his career to Dwight D. Eisenhower Army Medical Center at Fort Gordon, where he had a transitional internship, and then went on for 10 years in the military. He was involved with the chief of the emergency department, a flight surgeon, and eventually completed his residency at East Tennessee State University here in Chattanooga, and is here talking today about hypertension and how to think about it.
Okay, so it's the end of the day. I don't know what I did to be down here, but only one person after me. We're going to go quick. High blood pressure and management strategies. The great thing about hypertension, and I'm not sure why not everybody's under control, most of the medicines are generic, so we can get them on something that they can afford. So hypertension is a condition in which the force of blood against the arterial walls is too high. These are the ranges for blood pressures. You got normal, less than 120. As we heard earlier, blood pressure of 115 over 70, you have very little risk of developing PAD, heart disease. As you go up by 20 over 10, it gradually increases. Elevated blood pressure at 120 to 129, less than 80, stage 1, stage 2. Treatment strategies, normal blood pressure. You want to promote the healthy lifestyles that we've talked about several times today: diet, exercise, smoking cessation, weight loss. If you have elevated blood pressure, you want to start with non-pharmacological things. Again, diet and exercise, therapy, recheck in 3 to 6 months. If they remain elevated, start pharmacological treatment. Stage 1 with no cardiovascular risk factors, or the 10-year cardiovascular risk, the Framingham that we heard earlier, that you want to do the same as above. You want to do non-pharmacological treatment, and then if you can't get them in 3 to 6 months, then proceed to pharmacology. Stage 1, stage 2, you can read those. The big one here is you want to assess for non-compliance. If you put them on medicine, and I don't know how many of you get those little things from the insurance company that says, hey, you may have a patient that's non-compliant, they're not refilling their lisinopril. And then you always have to approach that with the patient, and sometimes they do, sometimes they don't. They take it every other day, take a half of the dose. So hypertension and peripheral artery disease. High blood pressure can damage the arteries. We've heard this. as the day's gone on. As the arteries are damaged, then the cholesterol problem comes in, starts to cause the plaques and the narrowing of the arteries. And if you have PAD, you're more likely to have disease in arteries in other parts of your body that increase risk of heart disease, heart attacks. Hypertension, how does it lead to it? Again, damages the wall of the arteries, in turn makes it easier for plaque to form. Plaque's the waxy material made up of cholesterol, other things like triglycerides, and can cause arteries to become narrowed, limiting blood flow. Uncontrolled hypertension. You double the risk of dying from heart disease or stroke, again, if your blood pressure goes up by 20/10. And if you have diabetes, hypertension increases your risk for complications. Non-pharmacological treatment. You want to maintain a healthy weight, BMI of less than 27. In the South, I mean, I grew up in Southern California, but in the South, I shoot for people to hit a BMI of 27. Because when you look at them and they're 33 and you say, hey, you're 6 foot and you're supposed to be 170 pounds, they go, oh, I've been 170 pounds since I was a freshman in high school. So try to get them, I try to shoot for 27. Obviously, 24 is the big standard. Waist circumference, a lot of things us primary care doctors don't do is measure their waist. For women, you want less than 35. For men, less than 40. Diet. I always encourage my patients when they want to try to lose weight is to keep a food diary. If they have a place of accountability for 2 reasons, they write down what they're eating, and then when I always make them bring in their food diary, then I get to see what they're eating, and then I can nitpick the hell out of a food diary. Excuse my language. All those years in the Army. Portion sizes are a big thing. As Brandy could probably attest to, the diabetic educators that come around to the offices, they have some handouts that show plates and plate sizes and what you should eat. Increase your fiber, water, watch your sodium. Exercise, I always recommend 30 minutes. A lot of people are going to have to start off with 5 minutes, work their way up, a couple weeks, they'll get up to 10, so on and so forth. Even during the pandemic, I tried to encourage people, said, look, you don't have to join a gym, you don't need to buy a piece of equipment. Get your hiney out with a decent pair of tennis shoes and walk your neighborhood. You don't even have to wear a mask if you're not walking with other people. Limit your alcohol. Here's where us men get to strive a little better. We get 2, women only can have 1 per day. And then control stress, anger, learn to time manage, learn and practice relaxation techniques, yoga, meditation. They work very well. Those of us in this medical field, we need to learn to control our stress. Maybe not so much anger, but stress. So pharmacological treatment should start with 1 of 4 drug classes. You have your thiazide diuretics, calcium channel blockers or antagonists, angiotensin receptor inhibitor or angiotensin converting enzyme inhibitors, ACE inhibitors, and angiotensin receptor blockers. Treating hypertension with selected comorbidities, atrial fibrillation. ARBs can reduce atrial fibrillation reoccurrence. It happens by controlling atrial remodeling. Standard still to use probably a beta blocker or a calcium channel blocker to slow down their heart rate. Aortic disease, particularly thoracic aortic disease, you want to use beta blockers. In chronic kidney disease, ACE inhibitors, ARBs, an ARB if an ACE inhibitor is not tolerated. Diabetes, ACE inhibitors, ARBs, they both protect your heart and your kidneys from the effects of diabetes. Heart failure with preserved ejection fraction, diuretics for volume overload, and heart failure with reduced ejection fraction, we want to use guideline-directed medical therapy, beta blockers, and avoid dihydropyridine calcium channel antagonists. Peripheral artery disease, first-line therapy. Those first 4 that we just talked about. We want to try to prevent the damage to the endothelial lining and developing more serious problems. Post-kidney transplant, calcium channel agonists, they can actually improve graft survival and your glomerular filtration rate. In the first month, you want to target blood pressure less than 160/90 to avoid any kind of thrombosis. And then secondary stroke prevention, thiazides, ACE inhibitors, and ARBs, or combinations thereof. Stable ischemic heart disease, again, your beta blockers, ACE inhibitors, ARBs, and then angina, beta blockers. Post-MI, beta blockers, aortic stenosis, you're going to initiate with a low dose and titrate up slowly. You don't want to prevent any further complications. Then aortic insufficiency, avoid drugs that slow the heart rate, beta blockers, non-dihydropyridine antagonists. Special treatments, African Americans, African descents, you want to consider calcium antagonists. Dihydropyridines are more potent vasodilators and are used more for hypertension. Non-dihydropyridines are less potent vasodilators and better for contractility and conduction. Alpha blockers reduce arterial resistance, relaxing muscle tone of the vascular walls. Alpha-2 receptors reduce blood pressure by decreasing the activity of sympathetic portion of the involuntary nervous system. Combined alpha and beta blockers used primarily in the ICU for hypertensive crisis and urgency. Peripheral adrenergic inhibitors blocks neurotransmitters in the brain, and it blocks the smooth muscles from constricting. Blood vessel dilators cause muscles in the blood vessel walls to relax and allow dilatation and increased blood flow. Considerations. Choosing the correct treatment for hypertension depends on many factors to include age, race, comorbidities. When able, you want to consider non-pharmacological, and I would continue that through the life of the time that they are being treated. Encourage diet, exercise, smoking cessation, and when pharmacological treatments become necessary, do not discontinue the non-pharmacological treatment. And that's it. Short, sweet, and to the point.
All right, that was excellent. Thank you so much. And I think you get the award for the shortest discussion today. With the high density of knowledge, that's what we love. Next, I'd like to introduce Robin Smith. She is a critical care nurse who is, I believe, it's critical care. That's what you did a long time ago, and she is our current representative for the Tennessee House of District 26. She is this also covers, or she represents Chattanooga and Hamilton County. She sponsored a numerous healthcare active proposals. She's involved with the Tennessee Right to Shop Act, which gives us an understanding of how to understand price transparency for different surgeries, things like this. She's also been a very strong advocate for permitting telemedicine for the existing Tennessee healthcare to allow us to have that outreach. And I'm sure she'll fill us in with all the other things that she's interested in doing. And with no further ado, Robin Smith to close our session.
Well, the good news is I'm last. You need your glasses? No, I don't. You know, someone left their glasses up here too. The good news is it's Friday, and I understand, like you guys, you've got a weekend to get to, and so I don't have slides. This is going to be very quickly. I'm going to summarize a little bit about why I ran for representation. It was really by accident, and as a former heart transplant cardiac care nurse, I witnessed firsthand how insurance became the decision makers in healthcare. And so I empathize greatly with you and understand that there is a role for insurance, but what I also know very dearly and deeply is the fact that insurance is not health care. And yet that's what we treat. That's the whole policy dialogue, is how can we keep premium costs down? How can we make sure everyone has insurance? Where, little trivia, I mean, I'll be 59 in about 7 months. And I remember when there was just Blue Cross and no Blue Shield. So what does that mean? It means that there was a hospitalization policy and a major medical policy, but you paid for your transactional health care one-on-one when you went to your doctor, when you went to your vascular surgeon. And it's interesting, if you parallel the increasing cost of health care, it's been paralleled right beside the increasing activity and control of insurance companies and the involvement of government as the payer, Medicare, Medicaid. And so what does that mean? The patient is here, the physician is here, the nurse practitioner is here, all the clinical team is here. The government and the bureaucracies are over here. They're so distant from the patient, and yet this is where the decisions are being made. And so the type of policies that I'm trying to put into Tennessee healthcare are transparency, accountability of these payers and these bureaucracies that have really perverted the open market so that we can see transparency, the pricing of things. If you and I right now were to go on a scavenger hunt, and I said, we're going to find 5 items. Whoever finds these 5 items first, you win the prize. And I gave you, someone get the cost of bread, a loaf of bread. Someone gets a cost of a set of 4 Michelin tires for a Yukon SUV, a 4-bedroom house on a certain street, a set of tickets for the World Series, Game 7, if they had gone that far, tomahawk chop. Anyway, and then the 5th would be a colonoscopy. You could find the prices of all 4 of those things except for a colonoscopy. Until recently, we're beginning to see some of that transparency. And when those prices are hidden, there's no competition. And so understand, when you're interacting with your patients, and you all do have some concierge medicine, and I applaud that because I'm all about returning some role of payment back to the patient. But understand, the reason the cost of health care are going up unabated, it's not because health care is really that expensive. It's because the costs are hidden, and there's a lot of $1,000 suits walking around in healthcare big systems, and there's a lot of middle management, and it's taking away from the care and the monies that are being shunted to care. So understand that whether it was the Right to Shop Act, whether it's the All Payers Claims Database, whether it was the bill that we just passed last year on Certificate of Need reform, which drives a lot of the care from outside the hospital into ambulatory surgery centers, which y'all have one right across the way. Those are things that make healthcare more market-driven, and I find it deeply ironic. Now, I was sitting on my computer the other night catching up on some work and saw a banner ad pop up on my internet browser. And it was an insurance company that will remain nameless, touting their pledge to telemedicine. I fought for 18 months and had to pull the bill because the insurance companies hated telemedicine. Why? Because the bill that I had, if you're Dr. Chris Lassar, and you want to use telemedicine, at one point you were only going to be paid a percentage of the office visit. And so I wanted parity of payment. If you deliver the same level of service but via telemedicine that you would in an in-person visit, you should be paid at parity. And the insurance companies hated that because they use contracted labor. So let's say that I'm a patient of United Healthcare, and I make a call in and I do a virtual session. The first virtual session, I may be talking to a nurse practitioner from Arizona. And then I need a follow-up, and so the follow-up is I'm with a PA from Delaware. And they're all contracted by United Healthcare. And then the third one, I'll be with a physician sitting on, in a condo in Arizona. And so they have their contracted labor, but that's not my doctor. Those are not my nurse practitioners. That's not my physician assistant. That person doesn't have access to my medical record. And so the reason that the telemedicine bill in Tennessee is so important and is so valuable, it treats every one of you as practitioners as the point of contact, and you're able to bill for telemedicine just as if you were being seen, that you have to document. But understand what a tremendous fight that was, and we're going to have to go back because that bill was only approved during COVID and for the pandemic. So we're going to have to extend the life of that bill. So be engaged with your state reps and state senators and let them know. But one of the things I wanted to bring to your attention, because I know how much you do fight with insurance companies, if you're finding some abuses relative to denials, if you're finding that the surprise billing issue, that you can understand that patients are being harmed, you absolutely can call me, email me. Dr. Lassar and his team knows how to reach me. And the Tennessee Department of Commerce and Insurance has an investigative function, and they will absolutely take care of if there are abuses for prior authorization or declining, denial of care, or some other abuse that's harming your patient care. Don't hesitate to engage, because there's an investigator that I work with a lot at the state, and we have absolutely reversed some of the abuses. And so there's a way for you to engage, and your government, your state government can actually help you. Not a tremendous amount, but insurance companies fear getting a call from VIC Trice is her name, and she's the investigator with whom I've worked before. So do understand that there is an advocacy role that you can leverage. And just finally, I know that we're entering into what I call the silver tsunami. And this is not real blonde hair. I decided to be blonde one day to hide my gray. And so the silver tsunami is coming. And what does that mean? That means that you as healthcare providers are more and more important to that aging population. And healthcare is going to look different. It's going to look different than it even does now. Because, while my mom is 79, she's pretty savvy on her phone. She's pretty good with apps and she's done telemedicine visits and things like that. She's not really good at driving in to a major, hospital, big system complex. She's better served in her home. And I think what we're going to see over the next, course of time is a growing demand for home-based care, not like home health care, but more home-based care, the telemedicine, doing things more in the community, interacting and empowering your patients and educating them. And so the last couple of sections, inputs on, smoking cessation and diabetes, those are so important because the more information you can give to your patients and give them control of what they're doing, sometimes it improves their compliance. Y'all know that. This is just, healthcare 101. But I do think that we're going to see, because of the remote monitoring that's permitted with whether it's blood glucose or other things that you can measure on a remote patient monitoring type of system, those are going to be things that are more and more important and become really part of your everyday assessment of your patients. So knowing that this is evolving, you're going to be fighting more and more with insurance companies. And I hate to say that, but it's really not going to get better, because as medicine evolves and improves and advances, there's going to be resistance and a natural conflict that insurance companies want to control that transaction rather than improve the lives and reduce that travel time or whatever that helps with your patient. So be resolved, because without healthcare providers, we don't have healthcare. And so be determined not to give in to insurance companies. And I hate to say that, but we need you to press in and be the advocate for your patients, because what we're witnessing is healthcare is moving from a patient-provider relationship to a managed medical transaction oversight, and it's growing and growing and growing. And I'm telling you nothing that you don't already know. But just understand there are many of us that serve you in Nashville that see that. We're trying to right the ship. But we need you to educate people about how important it is for them to shop their prices through their cost estimators and ask, how much does the healthcare cost? Because the more information that's out there, the prices will come down, and we literally want to disengage and take some of the power away from the insurance companies. And just a parting thought before I leave the stage, before I say thank you, the way Dr. Lassar and Tracy and I have worked together before, I did clinical. I also, there's a little acronym that I think you all may be familiar with called FLOW. That, if you have the feeling of pain in your distal extremities, if you have a loss of sensation in your distal extremities as far as walking, if you have open sores that just don't heal, if you've got weakness in your legs when you walk or a problem, well, that's something that we worked on together. And so before I was a state legislator, I was kind of unofficially part of the Vascular Institute of Chattanooga. And so thank you for making a difference in the lives of a lot of folks in this region. And I understand deeply and empathize completely with what you're having to do to fight to get your patients cared for. But please be sure to know that there are a handful of us in Nashville that are former caregivers, and that we want to serve you and make your relationship with your patient better. But thank you, and keep fighting. Appreciate you all.
So how can we close with anything better than those words? So it was natural to have Robin Smith come up and close for us. And I want to thank everybody here, specifically the speakers, for the efforts they put together to make the talks meaningful and knowledgeable. I want to thank the participants. I mean, this has been a long day, and it's a lot of information. It's hard to concentrate. Not many breaks, but we got through a lot of different things, talking about chronic disease in this region, talking about how to fix it, how to connect together, and really kind of what the idea behind Faces of PAD was all about to begin with. And so after this, this day, when you're coming into Faces and there's a lot of work to do, and you think how you're going to do all this stuff, but I really feel a great sense of accomplishment in trying to bring this for the folks in this region. A couple things: don't forget to fill out your paperwork to get your CME. It is free. You spent the time. You should get the reward. If you haven't filled it out, you need to run, then expect an email in the next couple days that you can do it online. Please let friends know that this was live. It was also live virtual and also recorded. So the CMEs can be gathered with friends over the next 3 months, and you can go back and review different things. There's a lot of detail in some of these these talks that I'd probably have to go back and review myself. So thank you for your attendance, and I thank you for your attention, and I wish you all a great weekend.